Hello, everyone. Thank you all for joining. Our meeting today will be about major depressive disorder, much more than sadness. My name is Rashad Nawfal. I'm a Lamsa ambassador and fifth-year medical student at the Lebanese University. This meeting today will be heavily influenced by Dr. Wadia Najjar, which is my professor of psychiatry at the Lebanese University and co-founder here at Lamsa. So before starting, Lamsa is the Lebanese Association of Medical Services for Addiction. It's an NGO with the slogan of youth empowering youth. And it's a medical student-run NGO. Can you hear me well? Is everything okay?
Yes.
Okay, so the main problem in mental health are the fallacies and myths and misconceptions. This is a recent paper, and as you can see, up to 50% of respondents in developed countries believe that mental illness is similar to physical illness, which means that half of the people actually think that mental is different than physical. I mean, the brain is an organ, the kidney is an organ, the lung is an organ. Why on earth would they be different? And yet, in developed countries, around 50% of people believe that mental illness is different than physical illness. It's a physical illness, I mean, it's a brain disease. So it is our responsibility to debunk those fallacies. And thinking of depression as any other physical disease will lead us to a better understanding of the pathophysiology behind it, as we will develop later on in this presentation. In medicine, if someone has pneumonia, we go with chest x-ray, and it's fairly easy to diagnose the problem. What is trickier is how to define if someone is in good health. This is tricky. We have to look at the physical, mental, and social aspect. If we go back to around 460 BC, Hippocrates identified it's a brain disease. And unfortunately, until today, there's this misconception that mental health is not a physical disease, whereas in antiquity, some people could identify that it's a brain disease. Can I please know in the chats how many believe that mental disorders do not have a genetic basis? Does anyone here believe that there's no genetics involved in mental disease? So very good. The famous novelist Hemingway unfortunately committed suicide. What's interesting is that in Hemingway's family, there are 5 suicides across 4 generations. Hemingway's father, Clarence, his siblings Ursula, Lester, and Ernest, and his granddaughter Margot, all unfortunately committed suicide. This silly example hints towards there's a genetic basis for mental condition. Most of us would say at some point, I hate my life. What's this life? I wish to end it. But there's a big gap between saying this and actually getting to kill yourself. Being humans, we have an instinct for survival. All of us go through moments where we question life. I wish I wasn't there. I wish I wasn't alive. I have issues and stresses. But going from there to suicide, there's a long way. Now we are going to move to depressive disorders. There are different categories for depressive disorders. One of the many types of depressive disorders, such as seasonal affective disorder or premenstrual dysphoric disorder. Today, we are going to focus on one disease, MDD, major depressive disorder. Why? Because it's the most common of them all. As the name implicates, we are dealing with depression. So we go back to the DSM, which is a reference we use to define mental diseases, such as major depressive disorder. As you can see, there are two cardinal symptoms, which are depressed mood and loss of interest or pleasure in all or almost all usual activities. By definition, 5 or more of the following nearly every day for at least 2 consecutive weeks. One major source of confusion is the difference between having depression and just feeling depressed. Almost everyone feels down from time to time, getting a bad grade, losing a job, having an argument. Even a rainy day can bring on feeling of sadness. Sometimes there's no trigger at all, and it just pops out of the it just pops up out of the blue. Then circumstances change, and these feelings of sadness disappear. Clinical depression is different. It's a medical disorder, and it will not go away just because you want it to. It lingers for at least 2 consecutive weeks and significantly interferes with one's ability to work, play, or love. Some clinical observable changes of major depressive disorder can include smaller frontal lobes and hippocampal volumes, which are areas in the brain, which is thought to originate, according to the literature, to brain cell death due to high states of cortisol, which is also called the stress hormone. On a more micro scale, depression can be associated with abnormal transmission and depletion of some neurotransmitters, such as serotonin, norepinephrine, and dopamine, and blunted circadian rhythm and dysregulation of hormones. But okay, so this is a very interesting study which correlates the size of the hippocampus, which we talked about earlier in this slide earlier. The hippocampus is the area in the brain which is responsible for long-term retention of memory. And in depression, this area shrinks. With increased fitness, this area actually increases in size, which also hints towards the effect of activity, external factors, and genetics on depression. So neuroscientists still do not have a complete picture of what causes depression. It seems to have to do with a complex interaction between genes and environment, which we will touch on more in a bit. So we do not have an accurate tool to measure where or when it will show up, which makes it particularly hard to know which person is fine and which person is actually struggling. What would be the best definition for depression? This is an old definition from 1997. Major depressive disorder is a malady of stress adaptation in the brain or a disorder of stress response and adaptation. It's all about neuroplasticity. Neuroplasticity being the ability of the brain to modulate its connections in order to better deal with outside stressors. And this is actually how psychotherapy, which is the first-line treatment for depression, works, as well as pharmacologic treatment. It provides the brain with better neuroplasticity, according to PET scans and research evidence, in order to better deal with outside stressors. There are many effective treatments, many medications, and cognitive behavioral therapy, or CBT, complement each other to boost brain chemicals. In extreme cases, electroconvulsive therapy, which is a controlled seizure in the patient's brain, may also be helpful. Now, about the epidemiology of depression, major depressive disorder is twice as prevalent in females as it is in males. 2/3 of depressed people have multiple episodes. The risk of recurrence progressively increases with each successive episode. The prevalence is unrelated to race, education, income, or civil status. lifetime rates vary greatly across countries between 1.5% and 19%. The lifetime prevalence of depression in the US is about 16.2%. In Lebanon, it's very close to the prevalence in the US, but the studies in Lebanon remain particularly scarce. This was a great study done in 2003, where they recruited 847 subjects in the UK. The assessment was over 25 years, beginning from the age of 3. Stressful life events were defined as romantic disasters, grief from the loss of a loved one, illnesses, and job crises. And then depressive symptoms were assessed. These participants, these 847 participants, were split into 2 groups with respect to a particular gene, which is the serotonin transporter gene, which has 2 alleles, the short allele S and the L normal allele, which is long. What was shown that with 4 or more stressors, 33% with the S allele were depressed versus only 17% with the normal L allele, which hints towards there's a 2 times increased chance for depression with the S allele compared to the L allele. This isn't the only gene implicated in depression. There are many genes, but this one was shown in this research. So genotype alone is not sufficient to predict onset of depression. Number of stressful life events was significantly associated with occurrence of depression. Now for the recurrence, after a first episode, there is a 50% chance of recurrence. After the second episode, there's a 70% chance. And after a third or more episodes, there are 90% chance of recurrence of depression, which means that finding depression early and treating it early, mainly with psychotherapy and medications, can influence greatly the percentage of recurrence after some time. Now for the conclusion, if you know someone struggling with depression, please encourage them gently to seek out some of the options we talked about earlier. You might even offer to help in specific tasks, like looking up therapists in the area and making a list of questions to ask a doctor. To someone with depression, these first steps can seem insurmountable. If they feel guilty or ashamed, point out that depression is a mental condition, just like asthma or diabetes. It's not a weakness, nor a personality trait. They should not expect themselves to just get over it, any more than they can will themselves to get over hypertension, diabetes, or even a broken arm. According to the National Institute of Mental Health, it takes the average person suffering with a mental illness over 10 years to ask for help. If you haven't faced clinical depression yet, please avoid comparing it to some times where you felt down. Comparing what they are experiencing with normal temporary findings of sadness can make them feel guilty for struggling. Even just talking about depression openly can help. For example, research shows that just asking someone about their suicidal thoughts can actually reduce their suicide risk. Open discussions about mental health can help erode stigma and makes it easier for people to ask for help. And the more people seek treatment, the more scientists will learn about depression and the better the treatments will get. So thank you everyone for joining today. If you're new here to Lamsa, or if it's the first meeting you attend, I highly urge you to follow us on social media. We do every Wednesday a weekly webinar, and thank you everyone for joining. Any questions?
Very nice and clear presentation. Thank you, Rashad.
Thank you everyone for joining. So is there any question or is everything clear? Thank you everyone for joining. Have a nice evening.